first question on knees and winter, Tony. Why is it more in winter that we get more complaints about our knees and some of our joints?
Without generalising, I think the obviously by definition is climate, cold, damp weather. We don't know the exact science behind it, but it's an acknowledged fact that people with arthritis in particular will experience an exacerbation in symptoms during the winter months. And it's very common that people will say, I go to Lanzarote for a couple of weeks and my knee feels a lot better. It is a fact that people feel that their aches and pains are worse in cold, damp weather.
So it's not just an excuse to have a winter break in Gran Canaria. It is actually a fact.
Yeah, it's an acknowledged phenomenon that people do experience more disabling discomfort in the winter months, and obviously the way to deal with that is to keep active, take painkillers when necessary, and battle through.
And for people who are at home and people who are listening today at home, what would be the tips you'd give for a bit of knee care that we could all start doing immediately?
It's about keeping active, keeping the muscles strong and the joint mobile. One of the comments I make to patients is if you sit around with your feet up, obviously human nature thinks, if I rest it'll go away, but actually it's often the opposite. By maintaining joint health with regular exercise, muscle strengthening, trying to keep your weight under control, all these factors are beneficial. Physiotherapy is really, when patients are sent for physiotherapy, they're told very, very much the same thing. It's not what the physiotherapist does to the joint or does to the patient that improves things, it's that help and guidance to rehabilitate or to maintain the optimum function.
And just give us an idea, how long have you been doing what you do? How long have you been looking at people's knees?
I've been a consultant for almost 30 years. I've been a doctor for 10 years more than that. So I've seen and treated patients of all ages with knee problems, ranging from children and teenagers to the elderly. I think the oldest patient whose knee I replaced was 96. So it's never too late to seek the appropriate treatment.
And is there much that surprises you now then, having got all this experience?
I wouldn't say surprised. There are always slightly unusual presentations, but given that experience, having seen tens of thousands of patients and done similar numbers of operations, then I hope to think that I've come across most problems, or at least have the knowledge and experience to know when something needs to be done, or whether they sometimes need to be sent to somebody else.
And with all your experience, what could you tell us about picking up on the early signs? I think there's a phrase, no pain, no gain, that kind of has made a lot of people think that when they go to the gym or when they do exercise, that it will be normal for the body to hurt. And maybe it stops us picking up on some of the warning signs, some of the early warning signs, which maybe, if picked up on, could prevent bigger problems later.
I think the problem with answering that question is that knee symptoms reflect a huge spectrum of conditions. So it's the nature of that pain. When I'm teaching medical students and trainees to identify the problem, they get very focused on what an X-ray will show or what they can find on examination. But it's really about the history. And when we're talking to patients, it's say, well, what is the pain? Where is it? How did it start? What's it associated with? Do you think it was triggered by something? Is it there all the time? Did it come on suddenly? And all these factors help us work out the source of that symptom. So it could be, irrespective of age, it could be a minor cartilage problem, which is a gristle between the joints, or it could be early wear and tear of the joint surface, or it could be a specific ligament injury. Ligaments are cords or straps of tissue which hold everything together, and they can get sprained or strained. So in common sense says, if it's repeatedly troublesome, think about it, seek appropriate advice. A little bit of niggles from time to time, particularly in middle age and older years. If they're not disabling, then persevere. But in terms of no pain, no gain, I think, I tell patients not to go out of your way to make it hurt. But if it hurts a bit after certain activities and then settles down, there's no harm in doing as much as the knee will let you.
And when you talk about people who come to you and they're fed up because they're not able to do something they love doing, when you can give them advice and treatment, it must be really rewarding.
Oh, tremendously so. I mean, particularly in the patients with disabling arthritis who benefit from joint replacement surgery. You know, the number of times I've heard people say, I feel 10 years younger, I've got my life back, etc., etc. Our objective when doing joint replacement surgery of the knee in particular is to achieve what we call the forgotten joint. You know, years ago we used to tell patients our aim is to get rid of the bulk of the pain, whereas nowadays it's really that forgotten joint where, you know, we see patients coming, for example, for treatment for the second side, and they say, I've forgotten I had the other one done. You know, it's not always plain sailing, can be a bit of an ordeal, but it's, you know, what our role is to determine the right thing to do at the right time. And I think, you know, symptoms are so subjective. One person's screaming agony is another person's bit of a nuisance. And, you know, the way we assess the severity, you know, patients come to me and look at the x-ray and then look in my eyes and say, how bad is it, Mr. Gibbon? And I say, well, it's as bad as you tell me it is. And then when we're assessing the severity of an arthritic condition, you know, we ask 4 questions basically. You know, how far can you walk comfortably? Do you get pain at rest? Do you get pain at night? But more importantly, what does it stop you doing that you think an otherwise healthy person of your age should be able to do? For an 85-year-old who can get around the supermarket and then have a bit of a rest at the end, don't really want the trouble and inconvenience of and the risks associated with a significant surgical procedure. On the other hand, somebody who's just retired and wants to play golf or, you know, go hiking in the Dales, they're miserable because they can't associate with their friends, and you know, it's justifiable to offer for them surgery as long as it's the right diagnosis.
And as well as surgery, can you talk us through the other treatments that are available?
Again, as we were alluding to earlier, you know, physiotherapy, physical therapy, exercise, just maintaining a healthy lifestyle, keeping the muscles strong, can delay the need for surgical intervention. There are other measures such as simple painkillers, even simple knee supports can be a benefit in some circumstances. Injection therapies, there's a whole host of more modern therapies available, some of which aren't completely proven yet, but many of our patients benefit from periodic cortisone injections, which is a steroid injected into the joint, a bit like having the blood taken, and that can be done in outpatients 2 or 3 times a year to help things settle down. Some patients will develop what we call an acute flare of arthritis, so a knee's got an evolving wear and tear or development of arthritis, which has been present for some time and is manageable, but then suddenly symptoms can present quite acutely, and they say, you know, last week it just became horrible, and then one wouldn't justify going in with a joint replacement on the basis of such a short flare. And in those circumstances, either it'll settle down by itself with the measures we've alluded to in terms of painkillers and physiotherapy or exercise, comparative rest, or a cortisone injection can help settle things down. But obviously if that sometimes doesn't settle down, that becomes a manifestation of a deterioration which will benefit from definitive surgical treatment.
And for somebody listening to this who's identifying with some of the things we're talking about, what would be your first piece of advice to them today?
Seek advice. The number of times I've heard patients seeking advice in the local community, they'll hear sort of 25 different opinions from 15 different people. So it's consult your GP or see a physiotherapist. Often people will go via a sports therapist or a physiotherapist, be it in the community or privately. The GPs, surgeries often have an in-house physiotherapist nowadays, or a musculoskeletal practitioner. Manage it yourself to start with, simple painkillers, exercise, but if it's getting worse and getting you down, then obviously it's speak to somebody who hopefully knows what they're talking about.
And you're a big part of the team here at Clifton Park Hospital, and obviously it's been great to pick your brains today. What is your favourite thing about what you do here? Helping
people get better. I mean, it's great to work with a supportive team. I mean, I've thoroughly enjoyed my surgical career, and it's the satisfaction of lots of elements of that. Firstly, sometimes we see patients in clinic who we don't need to operate on, but by giving them the reassurance and the advice that is appropriate, you can see the anxiety or the concern, the worry lifting from them, saying, oh, great, you tell me what the problem is, I know how to deal with it. You've reassured me that there's nothing sinister or serious going on and we don't need to do anything more. But then there are diagnostic challenges So in other words, working out, I mean, actually people this morning who's come along and said, I'm not going to do anything to them, but we've identified the problem, reassured them that there's a management plan, and they go away happy. Secondly, obviously as a surgeon, operating is a major part of it. And if you didn't enjoy that, you should be doing something else. It's technically satisfying. You're working with your hands. I do a variety of procedures with different technical demands or challenges. So we do keyhole surgery, arthroscopic surgery for soft tissue problems such as a cartilage problem or ligament reconstruction. Patella realignment, so stopping kneecaps being wobbly or dislocating. And obviously joint replacement, as we've talked about. And all of those demand different skill sets, working with lots of different types of instruments, ranging from telescopes to power tools, hammers and saws, and then at the end of the operation you get a feeling of satisfaction of completing a task, but more importantly seeing that patient get better and coming back to clinic is quite humbling and rewarding.
But it's really interesting. There's a buzz from doing the surgery, doing a good job of the surgery.
Practical satisfaction, as you say, doing a good job, whether you're building a wall or mending a fence. We're dealing with people's quality of life. An added layer of satisfaction. I'm sure, when I've had work done at home and tradesmen are proud of what they've done and enjoy our gratitude and thanks. It's similar, but on a different scale because it's people's lives.
From everybody we've spoken to when we've been chatting, there does seem to be a general sense of everybody in the team here enjoys helping others.
You couldn't do it by yourself. I mean, I'm at a stage in my career now where some of my peers have retired in different professions, and they say, you not get fed up of it, why are you still doing it? I say, well, it's like playing in my garage, only somebody gets the tools out and puts them away afterwards.
And you get a lot of satisfaction from teaching others?
No, teaching, yeah. I mean, I've trained dozens, if not hundreds of surgeons over the years, many consultants throughout this country and abroad as well. Visited some of them in India and lectured and demonstrated surgical procedures in lots of places. But yeah, seeing people, I mean, it's the same in any profession. If you're nurturing people's development, that's an added level of satisfaction. But going back to teamwork, as I said, every element from the receptionist to the clerks to the theatre staff to the nurses, they're an invaluable part of the patient journey.
And it's the care is not just the surgical care, is it?
No, not at all. I mean, all those elements contribute to patient satisfaction. If they get the right letters, they're told to come in at the right time, they're greeted by a friendly face, not inconvenienced, that really does help people's recovery and overall satisfaction. It's the same customer care that you get in any service provision, really, but it's even more important when it's about people's health. There are always elements where the hiccups occur and patients don't always understand what's taking place, and it's ironing out those hiccups which, if a patient's unsure and don't know what's going to happen to them, that creates anxiety, and that can contribute to an adverse outcome, irrespective of how good the surgery is.
When we talk about winter care, just thinking of one thing that is very popular in winter, ski trips. You'll get people who either need you before or after a ski trip, won't you?
Yes, I mean, talking about before skiing, there are people who have knee symptoms who are apprehensive or hesitant. They may have had previous trauma, or they may have evolving arthritis, or they may even have had surgery beforehand. And certainly I'm frequently asked, should I go? What do I need to do? Do I need to wear a brace? Should I stop? Whatever. And obviously, levels of skiing are very broad. I didn't ski until I was nearly 40, but I've been doing so for a number of years since, and touch wood, I haven't hurt my knees, but I've treated hundreds of patients who have, and also treated patients who've had arthritis surgery and then gone on to ski without a difficulty. So firstly, beforehand, maintaining joint mobility and fitness, exercising and getting muscle strong. So if you do no exercise, never go to the gym, never go for a run, never go for a bike ride, you are more vulnerable to skiing injuries, particularly if you're not a regular or very experienced skier. So it's about maintaining fitness, etc. There's no specific contraindication in my view. If a patient does have some troublesome knee symptoms, yes, vigorous activity may stir things up a bit, but you're not necessarily doing any permanent damage if you can tolerate it and take some painkillers. So people with evolving arthritis or even established arthritis are capable of skiing with appropriate measures, be it simple knee support, painkillers, etc. Obviously, you mentioned afterwards, when we go to a ski resort, by the end of the week, you'll see quite a number of people on crutches with knee braces. Some of those will be simple sprains, but very commonly, patients rupture their anterior cruciate ligament. We've heard about the ACL. Anybody who supports football will see that most Premier Leagues have several reconstructed ACLs running around the park after a year of injury. And again, it's about, have I ruptured my ACL? People will always know where they were, what the weather was like. It's a horrible feeling. It's more than a simple sprain. It's important if there's any suspicion of that. Obviously, in ski resorts, people will often see someone who's experienced help make the diagnosis, but even on return, or if you haven't managed to see somebody at the resort, if the knee doesn't settle down or feels unstable and wobbly, then get it seen, get it checked out either via a physio or come and see one of us.